Good afternoon. My name is John Ingram. Today's presentation is going to be understanding the complexities of right-sided circulation, and I have no disclosures with this presentation. Today we're going to be covering this basic outline. The first thing I want to do is pose 3 poignant questions regarding right-sided circulation. Hopefully you think you know the answers to, but maybe I can introduce some surprises onto these 3 questions. Then we're going to do a quick review of pulmonary anatomy and physiology and some of the complexities that poses for us when we go on cardiopulmonary bypass. I'm going to do the same for the bronchial circulation, the anatomy and physiology brief review, and then some of the complexities that poses for us when we're on cardiopulmonary bypass. And then I'm going to talk about comparing the right ventricle to the left ventricle, the various cardiac output. Are they the same? Should they be the same? Are they different? And then we're going to have a conclusion where by and large, we reveal the answers to the first part of the first 3 questions that I posed, okay? So question number 1 that I'm going to pose is, knowing that all the blood entering the left atrium comes directly from the pulmonary capillaries, why does the oxygen saturation in the left atrium never reach 100%? And why am I saying that? Well, in the famous anatomy and physiology book by Tortora and Dickerson, they state, ever wonder why the oxygen saturation is not 100% in the left atrium and left ventricle? And also, in an article back in 2009 titled Normal Oxygen Level and National Jewish Health, healthy individuals at sea level usually exhibit oxygen saturation values between 92 and 96%. And you can find this in nearly any textbook. In fact, if you were to Google cardiac chamber saturations, you would get a whole number of diagrams that would come up. But typically, it would look like this, where it showed you that somewhere in the left atrium or left ventricle, you had a saturation somewhere in the 90s. And by the way, if you do see one that shows 100% saturation in the left ventricle, they're being a little loose and fancy-free with the facts if you see that. That's never quite 100%. Normal individual on room air. Question number 2 I would pose is, knowing that our circulation is one big circle, of course, and the right and left ventricles are in series with each other, why do medical physiology textbooks say, for example, right ventricular outflow is approximately equal to the left ventricular outflow? And this comes out of the famous medical textbook, Pulmonary Physiology, 9th edition, 2018, by Michael Levitsky. And question number 3 I would pose is that every organ in the body experiences infarctions. However, the lungs are extremely resistant to infarctions. In fact, when is the last time you heard of somebody saying this patient had a pulmonary infarct? Why do we think that is? Well, pulmonary infarction occurs in about 10 to 15% of patients with a pulmonary embolus. Although in necropsy studies, of those with a lethal pulmonary embolus, only 60% of those even develop an infarction. And this comes out of Kushner and his colleagues' 2015 article, Lung Infarction Following Pulmonary Embolism. So let's just take a review of the pulmonary circulation and anatomy and physiology of the pulmonary side. And we're going to do the same thing for the bronchial side. And of course, all of you most likely know that the main pulmonary artery bifurcates to the left and right pulmonary arteries, and then quickly goes down to a dense network of pulmonary alveolar capillaries, where of course the hemoglobin in the blood conducts gas exchange. Then of course this blood then returns back entirely through the pulmonary veins, which carries oxygenated blood back into the left atrium. So when we look at the right lung and the left lung, the right lung is divided into 3 lobes, and it's larger and therefore performs 55% of the lung activity. The left lung is divided into 2 lobes and therefore performs 45% of the lung activity. Now let's discuss the alveoli. The alveoli are these tiny air sacs that sit at the very end of the respiratory tree and are the functional unit of the respiratory system. Their purpose is to exchange oxygen and carbon dioxide to and from the bloodstream. And by the way, we have approximately 300 million alveoli in our lungs. If you've never seen a normal pulmonary arteriogram, this gives you some idea how vast and dense network our pulmonary anatomy really is. Now let's look a little bit at pulmonary physiology. Well, of course, the major function of our pulmonary system is gas exchange. The pulmonary circulation supplies deoxygenated blood to the lungs, where the red blood cells, through the hemoglobin, release carbon dioxide and pick up oxygen that is later to be sent to the tissues. The secondary function, however, of the pulmonary system is lung tissue perfusion. Much of the lung parenchyma gets oxygen directly from inspired gas and from an extensive system of what's called supernumerary vessels. Those branch off from the arterial vessels and supply the nearby respiratory lung tissue. So there's a dual function going on there that's not talked about very often. Now, for maximum gas exchange, pulmonary blood flow ideally needs to match its ventilation. In respiratory physiology, the ventilation perfusion ratio, known as the VQ ratio, is a ratio used to assess the efficiency and the adequacy of these matching two variables. V for ventilation is the amount of air that reaches the alveoli, and Q for perfusion is the amount of blood that reaches the capillaries of the alveoli. Now, the VQ ratio is defined as the ratio of the amount of air reaching the alveoli per minute to the amount of blood reaching the alveoli per minute. And this gives you what's called a ratio of volumetric flow rates. These two variables constitute the main determinants of the oxygen and carbon dioxide concentration in our blood. Now, this leads to the concept of something called ventilation perfusion equality, or many of you have probably heard it known as ventilation perfusion mismatch, or VQ mismatching or matching, or VQ ratio. So ideally, the oxygen provided via ventilation would saturate the blood 100%. Now, knowing that 1 liter of blood holds about 200 cc's of oxygen and 1 liter of humidified air contains about 200 cc's of oxygen, therefore, the ideal ventilation ratio would be 1:1, or 100% saturation. In actuality, though, as I said, our arterial saturation is somewhere between 90 and 95% saturated. So the principal factor affecting this VQ gradient has to do with gravity's effect on the blood within our upper and lower lobes of our lungs. So, for example, the apex of the lung would have a higher VQ saturation, and the base of the lung is going to have a lower VQ saturation. And we're going to look at why this is. So standing or sitting in the upright position, gravity causes a greater amount of blood to travel or to pool to the lower lobes of the lung, and less blood travels to the upper lobes. At the base of the lungs, blood perfusion is therefore greater than the ventilation, which then lowers the VQ ratio, resulting in a lower saturation. In the upper lobes, blood perfusion is less than the ventilation, meaning there is an excess of ventilation compared to the amount of blood flow, thereby increasing the VQ ratio, and this results in a high saturation. VQ ratios change according to position. So you can't get away from this phenomenon, because even if you lie down, now the gravitational force does the same thing on the posterior aspect of your lungs as it does in the base of your lungs when you're standing. So you can't get away from this VQ mismatch due to gravity. But how does the force of gravity on the blood affect the VQ gradient between the upper and lower lobes of the lung? What's going on here? Well, if we look at the middle lobes, okay, you have a certain amount of air coming into your alveoli, and then you have the capillary coming by that alveoli with a certain amount of blood, and there's your Q and your V. And in the middle lobes, it's a pretty even match, which gives you about a 1:1 ratio, or 100% saturation. Now in the upper lobes, if you see there, the Q, the amount of blood going to those capillaries is somewhat less. The ventilation is the same. So we actually have a VQ that's greater than 1. But unfortunately, we can never saturate greater than 100%. So we end up with the upper lobes being 100% saturation as well. So far, so good. Now let's look at the lower lobes. Well, due to gravity, you see there the Q is much more distended. We have a much more fuller and distended capillaries that are coming by the same amount of air in the alveoli. And so we do not have enough ventilation to saturate all of this excess blood that is coming down through the lower lobes. And therefore we end up with a VQ less than 1, and we end up with about an 85% saturation of the blood that takes place in the lower lobes. If you take the average of these three, 100% upper lobe, 100% middle lobe, and 85% lower lobe, you end up with what we do have, which is about a 95% arterial saturation in our system. Now let's talk about the bronchial circulation and the role that it plays. It's a separate circulation entirely from the pulmonary circulation. The bronchial circulation node's primary function is lung tissue perfusion. Now it complements the tissue perfusion that's already taking place by the pulmonary circulation, which I said earlier, in the pulmonary circulation, the tissue gets oxygen directly from inspired gas and also from these supernumerary blood vessels that branch off from the arterioles in the surrounding area and perfuse lung tissue in the immediate area of the alveoli. But the bronchial circulation also perfuses the bronchi and the pleura. Now, the beginning of the bronchial circulation is from the descending aorta, and there's various different types of anatomy that we have. I've shown all 4 different types of arterioles that branch off from the descending aorta here, but most of us have 2 or 3 combination of these, and almost none of us would have all 4 of these, but suffice it to say that you have tiny bronchial arteries that branch off the descending aorta. And of course, the first thing that happens is this bronchial arteries will go to the tissue of the lungs, but what begins to become interesting is that instead of this now venous blood from these capillaries going back to our venous system, some of these bronchial capillaries directly fuse themselves into the alveolar capillaries and empty their venous blood into the pulmonary veins, mixing with the oxygenated blood that's in the pulmonary veins. A second thing that happens is some of these bronchial capillaries don't fuse with the pulmonary alveoli capillaries. They actually have their own venous drainage that connects directly into the pulmonary veins. And so we have a second section of bronchial capillaries that are emptying their venous blood into our pulmonary oxygenated blood pulmonary veins going back to the left atrium. And then there's these two together, these two amount of bronchial alveoli together account for about 75% of the bronchial venous blood that ends up being sent back into our pulmonary veins. Why am I pointing this out? Because the purpose of the pulmonary system is to fully oxygenate the lungs, fully oxygenate the blood, return that to the left atrium. And these two sections of bronchial capillaries are really being counterproductive to that because they're emptying their venous blood, which is now mixing in with the pulmonary veins on its way to the left atrium and causing less of a saturation contribution in a negative way to our overall saturation ending up in the left atrium. Fortunately, though, there is about 25% of the bronchial venous blood that actually traverses, as we would have expected it to, directly back into our superior vena cava via the hemizygous and azygos veins. If you've wondered what some of those purposes of those azygos and hemizygous veins are, they help feed the bronchial venous, 25% of the bronchial venous return back to our superior vena cava. Now, when we talk about bronchial physiology is a product of the anatomy. So as I said, bronchial arteries begin from the descending aorta. They carry oxygenated blood to the lungs, and it ends up into the bronchial capillaries where they provide perfusion to the lung tissues. 25% of this, as I said, these bronchial veins end up feeding back into the superior vena cava, but 75% of these amount of bronchial circulation is routed into the pulmonary veins and back to the left atrium. So this 75% of the bronchial circulation is a veno-arterial shunt. Now, in an article by Sharon and their associates, Bronchiovascular Congestion and Angiogenesis back in 1997, they state that the formation of new bronchial vessels, i.e. angiogenesis, occurs in a variety of lung conditions, chronic inflammation, infectious, and different pulmonary diseases. Now, this is in contrast to the pulmonary circulation, which generally does not very predisposed to angiogenesis at all, but the bronchial circulation has a remarkable ability to proliferate. Angiogenesis in the bronchial circulation is in response to a variety of lung conditions, lung infections, any type of ischemic or artery occlusion, lung tumors, and lung transplantation. So this is important because the bronchial flow has implications for extracorporeal circulation. As all the perfusionists would know, this persistent blood flow must be constantly vented or in some way accounted for as it enters the left atrium and causes visualization difficulties for the surgeon, something we deal with on a daily basis. Now, there's a complementary relationship between the bronchial and pulmonary circulation. Because of the dual blood supply to the lungs from both the bronchial circulation and the pulmonary circulation, this tissue is then extremely resistant to infarction. An inclusion of the bronchial circulation rarely causes an infarction because it can occur, but it can occur in large pulmonary embolism cases when the pulmonary circulation is blocked and the bronchial circulation cannot fully compensate for it. A unique characteristic feature of the pulmonary vasculature, as I said before, is this extensive system of supernumerary vessels that branch off at right angles from the accompanying arterial vessels and supply the nearby respiratory tissue. The functional significance of these vessels is to provide collateral flow to the surrounding tissues if the bronchial vessels are ever occluded. So let's look at some answers to those three questions that I posed. Why does the oxygen saturation in the left atrium never seem to reach 100%? Well, there's two reasons that we covered. The pulmonary circulation, due to the VQ mismatch produced in the lower lobes, where the saturation is only approximately 85%, is one reason. And because 75% of the bronchial circulation is a veno-arterial shunt, whereby desaturated bronchial blood is also routed back to the left atrium. How about question number 2? Why do the textbooks say right ventricular outflow is only approximately equal to the left ventricular outflow? Well, we go back to our bronchial circulation again. We know that it's a veno-arterial shunt. So what you have happening is arterialized blood from the descending aorta perfusing the lung tissue. And instead of going back into the venous system, that venous blood returns back into the left atrium. And by the way, this accounts for about 1 to 3% of the total cardiac output. So therefore, because of this, the left ventricular output must be 1 to 3% greater than that of the right ventricle. Question number 3, why are the lungs extremely resistant to infarctions? Well, due to the redundant lung tissue perfusion from the bronchial and pulmonary circulations, this tissue is extremely resistant to infarctions. Now I'm going to talk about a comparison between the right ventricle and the left ventricle in terms of the ventricular ejection fractions and their cardiac output. How does the right ventricular ejection compare to the left ventricular ejection fraction? Well, echocardiography is not a reliable way to measure the right ventricular ejection fraction. MRI is actually the most accurate means to measure the right ventricular ejection fraction, but you may be able to do it with a transesophageal echo, a TE. But if you look at regular echocardiography on an image, the right ventricular chamber volume appears to be smaller than the left ventricular volume. Here it appears the left ventricular volume is quite larger. But in actuality, the true anatomy, the right ventricular chamber is actually larger than the left ventricular chamber, as you can see here in a proper diagram. If we take the average 75 kilogram male, all your average person, and you look at, what is happening in the right ventricle volume-wise, Well, typically an average end diastolic volume of right ventricle might be about 145 cc's, the end systolic volume 51 cc's, and the stroke volume about 94 milliliters. This gives an ejection fraction of 65% in the right ventricle. If you take a heart rate of 75 beats per minute, this means the cardiac output of the right ventricle would be 7,050 cc's per minute, or 7.05 liters a minute. But if you look at the left ventricle, end diastolic volume is a little bit lower, 142. The end systolic volume is a little bit lower at 47 cc's. But the actual stroke volume then of the left ventricle is 95 milliliters. This gives the left ejection fraction being 67%. If you look at the heart rate of 75 beats per minute again, this gives the left ventricular output of 7125 cc's per minute, or meaning that the right ventricular output is actually 120 cc's less per minute, or conversely, the left ventricular output is 120 cc's greater per minute. So they are not the same. But why is this important? Due to the bronchial circulation, one must always account for the left ventricular output being somewhere around 2 to 3% greater than the right ventricular output. Now, in cases of managing an RVAD or an LVAD or even BIVAD, one must never overflow the right side in these situations due to the possibility of causing flash pulmonary edema. All right, guys, thank you very much for listening, and I appreciate your input. Let me see if I can bring up the Q&A here. Okay, I don't seem to be having any questions, so if you guys do, I'll be happy to answer them. Well, thank you for the compliments in the chat. Appreciate you guys listening.